Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Elbow.
We're going to be discussing an elbow procedure, and we have our patient Jacqueline. And if you've noticed, she's come with her sleeve rolled up. The elbows are exam, so you need to get the clothing out of the field of view. You may have to even put a patient in a gown depending on can they get that sleeve up high enough. The supplies again are pretty standard. Today we're going to use an 11 by 14. It is an extremity cassette. And we have our lead strips, lead markers. Our patient is already wearing her lead shield to protect the reproductive organs. Let me kind of introduce an elbow to you today. We're going to take 3 projections. You're going to do an AP, an external oblique, and a lateral projection. Again, you're going to do an AP, an external oblique, and a lateral projection. 3 on one cassette crosswise, so we will be dividing it to 3 sections. The ID blocker might cause you a problem in this procedure, plus some patients, their upper humerus is fairly large, has loose tissue. So we're going to be talking about some precious zone. Let's show them the precious zone first, Jacqueline, here. I think you can see her arm here. And I'm defining the precious zone as like 2, maybe 3 inches on either side of the elbow joint. And she can bend her arm. You can see the crease of any patient. And the precious zone, meaning this is really important. Don't clip any soft tissue in this area at all. Where the upper humerus, if there's extra tissue, it might overhang the lead strips. It's a fairly common procedure. Just don't have soft tissue clip in this area. The reason for that is there's fat pads in the elbow, and your workbook that when you study, you'll learn about those fat pads. They're in the soft tissues. If the fat pads are displaced out of their normal anatomical location, the radiologist will be able to determine what type of injury that this patient may have sustained because of the particular way the fat pads are displaced. So we do not clip soft tissue. Soft tissue is very important. 2 to 3 inches on either side of the crease. So that's some preliminary discussion for you to think about. Now, we have a left arm, and in a lateral position, this cassette will be placed to where the ID is going to hug that. Okay? That's how I want you to place the cassette when you're doing a left arm. If you were doing a right arm with the lateral position, the right arm, that's where the ID blocker will be. Okay? So you need to think about your laterals. The laterals will be with the humerus coming down this plane of the film, with the forearm going off the shorter axis. And you put the ID blocker with the lateral. ID will always be with the lateral, and with the left arm, that ID will be hugged. And with a right arm, the ID will actually be distal to the elbow. Okay? So you do some thinking before you actually start. What arm are you doing? Where will the lateral be? Remember, the forearm goes off the short axis of the plane. So if we're going to do our lateral here, then we would do our external oblique with the AP in the center. So you've got an external oblique going off, AP is straight, and the lateral forearm going off. So, her left arm injury, I want the lateral forearm going off and the ID blocker with the lateral. So that's my thought process, and I'm going to start with my external oblique over on this side of the cassette. Okay? Divide your cassettes into 3 sections. Let's Jacqueline, let's kind of mock something for a second. Class, I want you to put your arm basically out in front of you, kind of like how my patient is now. And an external oblique, you need to externally rotate that arm 45 degrees. Just turn your arm out, and you're going to feel that you're pulling and stretching those muscles, and that is not comfortable at all, okay? We can shake our arms out. Jacqueline, show them the trick. If they lean your shoulders into it, I want you to lean, class, and see how we can get Jacqueline's arm at a 45 degree, much easier than that arm is straight out there. So the trick is to put the shoulder, move the shoulder down, then you'll get your external oblique. Okay? We want to try to keep our legs from going underneath the table. I need the humerus parallel to the table, so she may have to, lean back or lean in. Do what you need to do. Sometimes elevating the chair will help that shoulder. Let's not let her roll out that far, because then we can have her shoulder lean into it. There we go. And then I want you to move very quickly. These patients are uncomfortable. I'm going to let my patient relax. I'm going to get my cassette close to where she was, and I'm going to get my tube close to the film. I never let the patient sit in that very uncomfortable position when I can minimize that time. So we're going to set our 40 inches to the tabletop. And we're going to move the tube longitudinally more over the cassette. You're going to get the collimation tentatively set. We're doing our preliminary work, and once we set our patient up there, then fine-tuning won't take us long at all, and that patient is in that uncomfortable position for a minimal amount of time. So I'm going to go back to my patient now. And can I have you stretch that arm out, please, and can we lean that shoulder? And I'm looking for the elbow here, both sides, and I want a 45-degree angle. Okay? The arm is going to come straight down the cassette. You okay? Mm-hmm. Central ray is to the center. Baby light over the lead strip. A little bit of collimation along the film's edge, equal on both ends. Can you lean in for me just a little bit? And then I have the crease of the elbow. You see that? I want the crease of the elbow where the central ray is extending to the center of the film. I need to look at soft tissue. Make sure you lean over the patient. I'll actually come around here so you can see where I'm looking. And I'm looking for soft tissue here. And I'll just explain it because I know the camera can't see this. I am actually clipping a little soft tissue up here by her shoulder. If I wanted to, I could slide her quickly over a little bit this way to clear all of that soft tissue from being clipped with a collimated edge. Her arm is small, it was easy to do. But somebody who had a bigger arm or who was muscular, remember this tissue up here might overhang, might be wider than your collimated field, and that's acceptable because it's beyond that 2 to 3 inch pressure zone on either side of the elbow. We're going to let her relax now because this is uncomfortable. And the camera, this way you can see it a little better. That's a left arm. I'm actually going to use the left marker, and I'm going to put it to the corner here. I'll lift this up so you can see. That's how I would place the L marker, because this is hung anatomical now. Shoulder up and hands down. This is the first upper extremity where it's hung that way. So this will be something different that you need to focus on. Okay? Again, this was an external oblique rolling off of the cassette. The elbow should be at a 45-degree angle, and the epicondyles will be to the center of the film. Capitulum and trochlea to the center of the film as well. the radiograph, when you look at it, when you evaluate the radiograph, what you're going to look at is the proximal ends of the radius and ulna. There should be space between the proximal ends of the radius and ulna if you've done a good job at your 45-degree oblique. Okay? Now, we've made that exposure, and we're going to do the AP in the center of the cassette. Again, I like to do my preliminary work before patients get into that position. So I get things tentatively set. And we're going to have her extend her arm again. The crease of the elbow goes right to the center of the film. Humerus is down. The palm of the hand is down, so the radius and ulna is parallel, and the epicondyles are parallel. I'm looking to see if I'm clipping soft tissue, and I'm clipping soft tissue. A little bit of soft tissue right in here is overhanging that lead strip. This is precious zone. This is not acceptable. I'm going to slide my patient a little bit over, and now I'm having soft tissue clearance here and soft tissue clearance on this side. Again, a little bit of overlap up here, but good clearance throughout. Now, our patient, if you can focus on her arm, this particular patient has a very straight arm. Sometimes I'll try to show you what's going to happen here. Sometimes the humerus kind of angles in and then takes off. There's like a slight curve to it. I want you to balance that. If that has that slight curve, you don't want the forearm perfectly straight. You don't want the humerus perfectly straight. You just kind of balance that slight curve where it comes down the center of that section. But I can't demonstrate that today because she has too straight of an arm. Okay? So let me review here. Baby light on both lead strips. Equal light here and here so I know it's centered. And the crease of the elbow, which is the capitulum and trochlea, that's right to the center of the film. Epicondyles parallel and the radius and ulna parallel. And we would make our exposure here in just a second. Some departments, I'm maintaining my collimated field all the way across. Some departments, you may see them collimating a little tighter. Can I have the camera come in and focus on this? Can you see right here? Okay. I wouldn't go any tighter than that. You're going to see a range of acceptability from film's edge to about an inch in. Whatever you do on your first one, you follow it through all the way across, depending on what your department's protocol is. Now we'll let our patient relax because it is uncomfortable. And our third projection will be our lateral. Before we do that, I'd like to review the positioning criteria on the AP for you. We put our capitulum and trochlea to the center of the film. The arm is straight. And if you have performed a good AP projections, that's with the epicondyles parallel and the radius and ulna parallel, the proximal ends of the radius and ulna will be slightly superimposed or slightly overlapped. And that, if you look at your radiograph, will let you know that you did a good job on your AP. Now our lateral. We need, again, the humerus down flat. Putting the humerus down flat will superimpose the epicondyles. And on a radiograph, you'll see a nice, round, penny-type shape. You need the humerus down so you superimpose those epicondyles. If you don't get the humerus down, if the patient's elevated like this, what happens is those epicondyles, instead of being perpendicular, they are tipped. And part of the humerus will be projected down into the ulna. And you don't want that. You want the nice round penny epicondyles with humerus not projected into the ulna. So we're going to lower the patient's humerus to prevent that. The arm is at a 90 degrees, and don't forget to put the thumb up. So the forearm is in the lateral position. I'm going to come and I'm looking at the radius and ulna here, making sure they're one on top of the other. With the radius and ulna in a lateral position, it will put the radial tuberosity in profile here. So we're going to position now, fine tune. I'm going to have baby light over the lead strip. Whatever amount of collimation you set up on your first projection is the amount that you're going to have here, and it's going to be equal on both ends. And my very first projection, it was to film's edge, so I'm going to take it back out because I don't want the stair-stepping effect of collimation. And the humerus is parallel. Check for soft tissue clipping back here. It's oftentimes that you're clipping soft tissue here that is not within your precious zone. And the ID blocker, I think it's hard for you to see this. The ID blocker is right here. I think we'll tip the cassette a little bit so you can see. Is that better? Okay. The clearance from the ID blocker, you need to make sure that this soft tissue doesn't get into the ID blocker. So the arm size may necessitate you shifting the arm down a little bit, like that, in order to clear the ID blocker. Okay? Because the ID blocker cannot be in your precious zone, again, because of those fat paths. And that's your lateral projection. If you've done a good job of positioning this on a radiograph, you're going to see the epicondyles perpendicular, nice round penny shape. Humerus is not projected into the ulna, and the radial tuberosity will be in profile if you made the forearm into a lateral position. The three humerus, let's kind of recap, Jacqueline. On this side of the cassette, we did the external oblique. Then we did the AP in the center, and then we did our lateral. Notice that the humerus are parallel on every projection. That's how you want to set up. Don't turn the forearm, for the lateral. Make sure the humerus stays parallel on all three of the projections. Do you have anything to add? Okay, just to recap, external oblique will open up the proximal ends of the radius and ulna. You want the capitulum and trochlea to the center of the film. The AP goes into the mid portion of the film. The proximal radius and ulna will be slightly superimposed. Again, capitulum and trochlea to the center of the film. And the lateral, if the humerus is down, the epicondyles will be perpendicular, that penny shape. And if you put the thumb up, the radial tuberosity will be on profile. Make sure you hang your marker like that, because that's how the radiograph is going to be. And don't forget you have that precious zone. Do not clip any soft tissue in your precious zone, which is 2 to 3 inches on either side of the joint space. And thank you.